You're welcome to the Policy Council. My name is Okwemi Agbaje. On this edition, we look at the healthcare sector in Lagos State. We know that healthcare is now a national problem. People go to India, they go to Egypt, they go to Germany, they go everywhere else but Nigeria to take care of their health. But only the rich can do that, or at least the middle class. What is government planning for the poor and for the vulnerable? I have the commissioner in Lagos State responsible for health to discuss this with me. Enjoy the program. You're welcome back to the Policy Council. Today my guest is the Honorable Commissioner for Health in Lagos State, Dr. Olajide Idris. He personifies the sector. He was the former permanent secretary in the same ministry. And together we'll review the state of healthcare services and the sector in Lagos State. Dr. Idris, you're welcome to the Policy Council.
Thank you very much.
Okay, let's start with an overview of your policy trust. What's the mandate of the Ministry of Health in Lagos State?
Well, basically and simply put, the mandate is basically to protect, maintain and restore the health of the people of Lagos State and to facilitate unfettered access of these people to health services irrespective, without any barriers whatsoever. And again, barriers have many dimensions. Could be physical barrier, could be financial, could be cultural, could be anything. So the idea is that we have to provide this service to these people, bearing in mind all these challenges, all these things.
So if the guy doesn't have money, you will still attend to him?
In fact, that is one of the major goals of the health sector. One is get the proper health indices, improve the health status, improve the response of the system to the people, and more importantly, provide the financial protection to the poor, because they are members of this society too.
Okay, I've been looking at the figures in terms of budgetary allocations in the Lagos State government, and 2013 I see 42 billion, significant resources. Almost 9% of the budgetary allocations.
Definitely.
And that's the average. And the last 3 years, the percentage allocation to health has been over 8.8 in 2011, 8.2 in 2012, 8.6 in 2013. So there's significant resources. How have these resources been applied? What are the main programs and activities that are going on?
Well, basically, I will go back a bit to when we came in, even the previous administration, I was part of it, and we looked at the system. There were so many things wrong with the system, and we embarked on a reform process as far back as 2004. And for that reform process, we had our strategies, and in this administration, we maintained a strategy with some slight modification, because it's like you've created a plan, you've charted a course. You must be able to maintain that course. So basically our strategies are numerous. One is to address the issue of infrastructure. Okay. Just like in any other thing, infrastructure refers to the hospitals, the clinics, the primary healthcare centers, schools of nursing, school of medicine and all. And the second one has to do with addressing the issue of a human resource for health. And we have a challenge in this environment, especially in Lagos State. If you look at the population of Nigeria and look at the population of Lagos State, you might say we have quite the largest number of health personnel, but the fact in reality is that if you compare that to the population of people we need to deal with,
so if you look at it per
capita, it's totally inadequate. So it's a major issue. That's number. And again, we had to address the issue of the skill mix, the quality of care and that kind of. So that's another strategy. The third one has to do with financing the health sector itself. Healthcare finance is basically generating resources for the sector. There is no country in this world that does not take that particular function very seriously, because no country. So, and over the years, financing in the sector in Lagos has been solely based on budget provisions, and we also feel that it's not totally inadequate, irrespective of what you say. So that's one. The fourth one was to address the issue of the primary healthcare system. We needed to revitalize that system, because over the years that has not been attended to over the years. And primary healthcare being the bedrock of any healthcare system, if we did not address that, whatever we do at the secondary and tertiary is just be a waste of time. And the fifth one was to some kind of regulation. And because you have to regulate whether players are in the sector, be it doctors, be it
private hospitals,
nurses, even the manufacturers, etc. There must be some form of regulation. And again, this state, we have about 55% of the population being catered by the private providers. And over the years, they had remained unregulated, and so we needed to put some form of regulation. We also address some issue of quackery and all sorts of things. So that's one. The sixth one was because of a huge population, the level of poverty, the level of education, we felt, and again, the paucity of resources available to us. Then they say prevention is better than cure. So we address the issue of healthcare prevention and health promotion. So those are basic things. And the last bit is, okay, you need to mobilize the people, get the people involved, especially people at the grassroots, to be able to cater. Those are the basic strategies we adopted in the health sector.
Okay. Let's take a short time out, and then we'll break this down and look at the primary healthcare sector, the secondary healthcare sector, and the tertiary sector. We'll be right back. You're welcome back to the Policy Council. I still have the Lagos State Commissioner for Health, Dr. Olajide Idris. So let's break it down. Now let's look at the primary healthcare sector. Like you said, it's the most important stage of. So in specific terms, what have we been doing?
Well, over the years, the infrastructure had been run down. And again, the mindset that people had always ascribed this system to the local government areas as their major function. But this administration felt that we could not allow this to go on. More so the amount of investment we put on the other sectors. If we don't address that sector, we'll be wasting our time. So we decided to fully address the sector. And looking at the challenges facing it, one has to do with the infrastructure. A major problem is actually staffing those facilities, because a lot of them, like for about 2-3 years back, you had about 277 primary healthcare centers, all function in different states of functionality. Very few function in 24 hours. A lot of them 8 hours a day. I'm totally inadequate for that kind of thing. And what we decided to do was address the issue of infrastructure. And we looked at it, look at the resources. We felt, look, you could not develop everything in one fell swoop. And what we decided to do was, okay, earmark a primary healthcare center in each local government area. We structure it, staff it adequately with both material resources and human resources, so that it can function 24 hours. We said we'll do that in each of the local government. It's a way to stimulate the thing, so that the local government council can now take us this.
What's the ideal staffing of a primary healthcare?
That is, each of those flagship must have 3 doctors to cover the shifts, about 8 nurses to cover the shift, and have the appropriate number of pharmacists, laboratory technologies, and all sorts also. But again, to do this requires a lot of money, so we said we'll face them. So that is what we are doing now.
Okay, the secondary sector, I imagine from what I saw on your website, that must be consuming a lot of resources.
Oh, definitely. But it is now, we have about 24 secondary care facilities in the state.
That's the general hospitals.
What we try to do is at least do phase refurbishment to build up the capacity in an area where they have shortage of staff, employ more staff, but more importantly now, raise the percentage, provide the wherewithal for the doctors and nurses to work with the right equipment, the right environment. But again, a lot of those facilities were built over the years, and so the culture of maintenance too, we had to put there. So it's a gradual thing. And again, to add to it, so for instance, in the context of the MDGs, there are some hospitals that did not provide maternal and child health services. And that's why at that level too, we decided to build the maternal and child centers to complement the services as one, and two, to address the issue of MDGs as a referral point to the primary healthcare facilities. So we are doing that. At tertiary level, the teaching hospital, you know what I mean.
That's been a huge investment.
It's a huge investment, because if you say Lagos is the center of excellence, we have operated a population of over 20 million people. Of course, that the population deserves more than one tertiary center. If we were to compare with other countries, I mean, Luth is there, that's one. But again, the second and again, we had to spend a lot of money to raise the capability of that facility. One, for many things. One, to provide an environment through which we could attract back those Nigerians in diaspora.
Yeah.
Two, to provide a platform to train the needed manpower, especially the specialist manpower in that kind of thing. Of course, because the fourth function of a teaching hospital is research, and to generate research capabilities too. So, and that's why we went a long haul to refurbish that whole facility. And again, mind you, that facility was not purpose-built for a tertiary institution. It first started as a cottage institution, became a general hospital, and so it also has its challenges. But again, we have to make do with what we have, and that's the essence of that. And at our apex, we really, and care house there too, that will be the apex level for obstetrics and gynecological services, and this is also undergoing refurbishment.
I wonder, is there any room? All of these are huge investments, and the state government is making it. But like you said, is there room for what's your policy in relation to public-private partnerships?
Over the years, if you look at the system, the healthcare system involves everybody, not only public hospitals and private facilities, private providers. And the peculiarity of Lagos State is that the private practitioners provide services to over 55% of the population. So that's a huge resource to them, especially in context of the shortage of manpower. So we have no choice but to partner with the private sector. So one thing we did, we started dialoguing with them, but again, we also need to regulate their service because there's also a lot of quackery. And that is where I mean, it's a conscious policy of government. But again, in the last couple of years too, we've also experimented, not only in service provision now, we've experimented in some areas, especially non-clinical services. If you go to Ikeja, the mortuary in Ikeja there is privately run. It's a PPP arrangement. The same with mortuary in Bagada. And also we also extended further now. There are some other services like scans, histopathological services that are also being provided by the private sector. We've gone further. If you look at a facility, the diagnosis center, Bola Tinubu Diagnosis Center, government built, financed the building and equipment, but it's a private person that is running because they are bringing the expertise, they are bringing capacity to run. So we're exploring those arrangements. We are building the cardiac arena center in Bagada now. It's in fact, it's almost completed, will soon be commissioned. The element is that we're bringing a private group with the correct expertise to run it over a period, and at the same time provide the capacity, impart knowledge and that kind of to our people. So it's a conscious effort to explain, and we're looking to provision, partner with private sector, even with the service provision at the primary care level, secondary care level, at the tertiary level, on clinical services. We have no choice but to go that route.
Okay, let's take another time out. I'm talking to Dr. Olajide Idris, Lagos State Commissioner for Health. We'll be right back.
Government wants our city to become a mega modern city, and so government is providing modern markets for us to carry out our business. Now, this requires money, so we need to pay our taxes to help government to help us. I pay my taxes. I hope you've paid yours. I pay. Pay your tax. It's your civic responsibility. It's your duty. It's the law.
You're welcome back. It's the Policy Council. I'm Okweyemi Agbaje, and my guest is Dr. Olajide Idris. And we're talking about the healthcare sector in Lagos State. Let me take some feedback questions. In preparing for this, my crew asked me to ask you a question. According to them, there's a practice in which general hospitals sometimes tell patients to come back in 2 months' time. Someone who has some serious illness. Often, and of course we know the consequences of that. 2 months' time, the disease may have progressed irretrievably. What does that happen, and why would that happen?
I won't say it is totally correct, but again, let me say again that I did tell you that there's a huge pressure on our hospital facilities. Level. Whether you like it or, the fact is that a lot of people are moving from the private sector into the public sector for many reasons. And because, like I did tell you, if the private care facilities were functioning well, don't be that low. So our doctors are overwhelmed. There's no doubt about that. And so I do also know in Ikeja too, with that facility, we have shortage of theater spaces. So the tendency is that you have to book patients, and again, you have to take the most critical first. And now, That's that. But I'm not ruling out the fact that in any organization you have people with wrong attitude, sharp practice. So that's right. So we've had instances of people too. Some doctors diverting patients to their facility. But by and large, the major problem has to do with the huge number of people they have to deal with, and everybody wants to be treated as even when you are serious, when you are not serious. To the person, his or her problem is serious. But to the doctor, he has to decide which one is an emergency first. So, but again, we are trying to address a lot of that issue. I think, for instance, now what we are trying to do is get the common case, surgical case, to be addressed in some general hospitals that have free theater spaces. So I'll say yes and no, but the reason being that the huge load on the doctors and nurses is a major problem. Again, I will not rule out the possibility of
Let me take this on, which I'm sure the Lagos public would want me to ask you. We've had, in the past few years, I don't think it has happened very, very recently, but we've had a fairly preponderance of strikes, doctors on strike, crisis between the doctors and the state government, and at a point, even some of us were worried that what's going on. Now, you give us what factors were behind those strikes, and have those factors been resolved?
Let me talk generally. The health sector is a very peculiar sector because you have many stakeholders, and each one trying to defend his or her own. So it's a sector that is ripe for, that's full of conflicts. So you are constantly trying to resolve conflicts. Having said that, our system, I must say, I will admit again that I'm looking at it from the national point of view now, because a lot of problems that states are having that are major reasons for these strike actions, to me, I believe has to be addressed at the national level. Because if you look at the revenue accruing to the federal government, and what proportion that comes to the states, you know, there is a mismatch there. And the problems are actually with the states and local governments. And Lagos has a peculiarity because we have a huge population to serve. Now, if policies are taken and state governments are not part of that policy, and you say we are running a federalism, then we are joking, because what the federal government can pay, a state government may not necessarily be able to pay. So I must admit again, whether I would like it or not, in this country, the health worker is not appropriately paid. But again, it's a reflection of the economy. And as a state government, we've tried our best at least to ensure, so we can debate it here. Looking at the resources available to us, I think the Lagos state government is paying reasonably well. So finance is a major problem and is a major cause of salary conflict.
Let's take our final time out, and we'll be back, in which I'll try to see the Lagos state government strategy for some specific diseases that afflict our people. We'll be right back.
Who knows a better thing? Abi who no like better thing? All these fine things where they see so. Now money government they take do now. Abi, it's like, you know, excuse me, I dey pay my tax. I dey do it, I dey pay my tax. Say you don't pay your own tax. Have you pay your tax? I pay, oh.
Pay your tax. It's your civic responsibility. It's your duty. It's the law.
You're welcome back. It's the Policy Council, and our guest is Dr. Jide Idris, Lagos State Commissioner for Health. Yeah, before I go into those core diseases I mentioned, the recurring problem in the health sector as even emerged from your discussions is financing. Do you have a strategy for sustainable financing in terms of health insurance and all of that? What's your attitude towards that?
Well, we've looked at it seriously, and we feel that is the right way to go. And because, like I did tell you, we've been solely dependent on budget provision to the health sector. No matter how it is, it's still inadequate. I'm looking at the provision we serve. And again, so that in the past, we have adopted some policies of free health. We also do know that free health is not sustainable. We can't fund it properly, and that's why we try to target to some population, children 12 years and below, adults 65 years and below. At the end of the day, to do realize that a lot of people still pay out of their pocket. And the tendency that, look, people who pay out of their pocket are the people who end up suffering because there's no pooling mechanism to cater for those poor people. And we've piloted some community-based health insurance schemes because we said we address the informal sector. We could do that where the huge is. So we've piloted this scheme in Ikosishere local government. We started one in Bejuleki and last one in Ajiromi. And we've done that now. If you remember, last week or 2 weeks ago, we had a State Council on Health. The theme was universal coverage. And the sub-theme is the healthcare financing and reducing maternal and child mortality. During that sub-theme, we gathered information and which we are now pulling together ideas to pull out, come up with a proper financing health insurance scheme for the state using the community base. So we're going to roll out very soon. I mean, but we need to enlighten the public because it's a change in direction. People, some kind of prepayment contributory scheme, and the government will have to subsidize, especially for the poor people with us. So we're on track.
Excellent, excellent. I'm happy to hear that. So let's, as we close, see what the state's government strategy is for disease specific. We have malaria, tuberculosis, HIV/AIDS. Can you talk about those ones first?
You know, malaria, we have a robust malaria control. I can boast of that many states do not even have that, even the federal government, because we have a control system in place, being implemented by a committee drawn from different sources, both public sector, the academia, and basically the idea was we adopted all the various control mechanisms, environmental control, vector control, treatment, public safety, and even research. And we went into the indoor residual spraying, which is what a lot of countries have done to be able to eradicate malaria. And we've done that in about 6 local government areas and 11 local council government areas, indoor residual spraying. And
tuberculosis?
Tuberculosis is a major burden. And once you have it, you have to be treated. If you have to be treated for at least 9 months with a full, and so it's expensive. We have that control issue, and again, the control measure also involves they are developing testing centers, rapid diagnosis centers, training people, and we have about 42 diagnosis centers now for TB. We have a major laboratory center in the mainland where now we are beginning to have resistant TB, and so we needed to address that. But again, with support from some external agencies, we build that structure there. But I must tell you, treating tuberculosis is huge, and in the context of HIV/AIDS, you know, they are twin brothers.
Yes, I wanted you to discuss
HIV/AIDS. So it's a compound issue too. We did a prevalence study for Lagos. It was about 5.1 for HIV/AIDS, but again, we have
5.1%.
Yeah,
and if we're 20 million.
No, it's quite high. Again, you have to look at the migration of people from outside of the state again. The migration of people from outside of the state again. So that's what compounds the issue. So we are doing that. We are providing treatment centers, counseling and diagnosis centers, also so many things. But again, the problem is that once you make the diagnosis, the person is on treatment for life. And again, cost of this is expensive. And this is also coming under the free health scheme because a lot of people there cannot afford that. So you can now understand the constraints government is having.
I would have loved to talk about some other major diseases, but we don't have time. But it's been an enlightening and educative discussion with the Lagos State Commissioner for Health. Thank you very much, sir, for coming.
You're welcome.
We'll be right back. That's been a very enlightening discussion, like I said. The Lagos State government now clearly has a clear strategy for the primary, the secondary, and the tertiary levels of health. And fortunately has made the discovery that seeking a sustainable financing system for healthcare is the only way we can cover the whole of our population. We wish them success so that our people do not die at home or die in India or somewhere else. Thank you very much for watching. See you next time.